Hello, so my name's Angela Dixon. I'm a practice nurse and I'm going to talk to you today about the microvascular complications of diabetes. There are several microvascular complications of diabetes, being diabetic retinopathy, which affects the small blood vessels at the back of the eyes, diabetic nephropathy, which affects your kidneys, erectile dysfunction for male diabetic patients, and also peripheral neuropathy. And it's going to be peripheral neuropathy that's going to be the main focus of the presentation today. So we're going to start off by thinking about a few facts about diabetes and foot disease. In any given week, 2 to 2.5% of diabetic patients will present to clinic with a foot ulcer. Of those patients who become ulcer-free, a quarter will present to clinic with another diabetic foot ulcer within 3 months, and some never heal. 70,000 lower limb amputations and limb salvage surgeries are performed on diabetic patients in England each year. A diabetic patient is 23 times more likely to have their leg, foot or toe amputated than a non-diabetic. And the NHS is spending more on diabetic foot disease than prostate, breast and lung cancer combined, and that data has come from the NHS in 2017. In England, if the prevalence of diabetic foot ulceration was reduced by even 1/3, this could be a potential saving of £250 million. Peripheral neuropathy is the most common microvascular complication of diabetes. It affects both type 1 and type 2, and hyperglycemia or high blood sugar will cause damage to small blood vessels. Nerve fibres responsible for sensation become damaged and disappear. This nerve damage cannot be reversed but can be treated to prevent further deterioration. Predisposing factors to peripheral neuropathy. Well, for the purpose of this presentation, the main predisposing factor will be diabetes, and up to 1 in 4 people will experience pain associated with nerve damage. Uncontrolled hyperglycemia or high sugar levels can also be a contributing factor, and it also appears to be more prevalent or common in people over the age of 40 years. And actually the longevity of the diagnosis of your diabetes can also be a consideration to take into account. High blood pressure and high cholesterol levels also impact on peripheral neuropathy, and when you come in for your diabetes reviews, we will speak to you obviously about reducing these, not only to prevent peripheral neuropathy but also to reduce any associated cardiovascular risk with your diabetes condition. Smoking constricts the blood vessels, makes them smaller. As a result of this, less blood and nutrients are delivered to the peripheral nerves, and any restricted blood flow prevents healing in any damaged area and will actually exacerbate symptoms. Likewise with alcohol. Alcohol is actually considered toxic to nerve tissue and will damage peripheral nerves. So when you come in for your diabetes review, you might find that the practice nurse will speak to you about addressing any excess alcohol intake. And finally, poor diet and lifestyle choices can also be a contributing factor to the development of peripheral neuropathy, and that data has come from the NHS in 2022. According to Diabetes UK, there are 4 main types of neuropathy. So there's peripheral neuropathy, and that means that this affects the nerves outside the brain and spinal cord, mainly the hands and the feet. Then you also have sensory neuropathy, which can affect touch, temperature, pain and other sensations. Again, this mainly affects the hands and feet, but it can also be present in the arms and legs. Autonomic neuropathy involves damage to nerves affecting the organs and the glands. It can affect the gastrointestinal system, temperature control, it can affect the heart, causing arrhythmias, and it can also be associated with erectile dysfunction. And then last of all, motor neuropathy. This affects movement and can lead to weakness, muscle wasting and ataxia or uncontrolled. Symptoms of neuropathy are actually dependent on the type, but can include loss of sensation, burning or shooting pain. This can be really uncomfortable. Another symptom can be loss of joint coordination. If you've got gastroparesis or gastrointestinal complications, this can cause bloating, nausea, constipation and diarrhea, and this is more prevalent in autonomic neuropathy. It can affect loss of bladder control, as we talked about in the previous slide. It can cause impotence, which impacts on sexual activity and erectile dysfunction. You can get associated gustatory sweating and an inability to regulate your temperature, and you can also get something called cardiac arrhythmias, which again is mainly present in autonomic neuropathy. So how is diabetic neuropathy diagnosed? Well, first of all, the clinician will take a clinical history, and this will include any worsening and relieving factors and also any variability. So for example, you might get asked, is it worse in the morning, is it worse in the evening, or is it a consistent problem throughout the day? Any recent infection will be noted, as will any exposure to toxins, including smoking, alcohol and illicit drug use. A clinical examination will take place, including a possible neurological exam. If you do have a neurological exam, this will look at things like your gait, your balance, and the examining practitioner will also check your reflexes. Nerve conduction studies and electromyography, or EMG as we like to call it, will look at the performance of your nerve fibres and how effective they are at transmitting nerve signals throughout your body. You may also be referred for a possible nerve biopsy. That will be done under local anaesthetic, sent off to the laboratory, and again the effectiveness of the nerve in transmitting electrical impulses will be examined. Additional imaging, including a CT scan, an MRI scan, an X-ray or a Doppler scan, may also be requested, and the purpose of the Doppler scan would be to assess if there's any vascular compromise or problems with blood flow in your extremities, such as your lower limbs and your feet. You will always ideally at each contact, but at least yearly, have a diabetic foot exam, and we'll talk about that in more detail over the next few slides. You may have any blood tests, and the blood test normally will be to check for your liver and kidney function, to check if there's any underlying infection which might be causing the peripheral neuropathy, and also to check your HbA1c, which is obviously the check that we perform every 3 months to maintain your diabetes glycemic control. If it's thought that you've got cardiac involvement, an ECG or an echocardiogram may also be performed. So let's focus now on the importance of the diabetic foot exam. As I said in the previous slide, this should be performed at least annually, but would hopefully be performed at every patient contact, especially if you feel that you are struggling with any loss of sensation or altered pins and needles or anything like that in your feet. And as practitioners, what we will be asking you as a patient is to describe any signs and symptoms that you feel are abnormal to you, and that will include pins and needles, loss of sensation, any ulcers and any abnormal feelings of hot and cold. At your diabetic foot exam review, you will also be asked if you're under the care of a podiatrist, and good foot care will be reiterated to you. You should be advised to wear wide-fitting shoes so that there's no constriction in your feet. Avoid barefoot walking, and the reason that we talk to you about avoiding barefoot walking is obviously if you have got any loss of sensation in your feet and you do stand on something and you're not aware of it, this could lead to an infection. So that's why we talked to you about the importance of avoiding barefoot walking. If you do cut your own toenails, or you have your partner or your carer do them for you, make sure that they are cut straight across, and always be prudent and vigilant in reporting any infections. The pulses in your foot will be checked. Now you have two pulses in your feet. One is on the top of your foot, and that's called the dorsalis pedis, and then you have one at the back of your ankle, and that's called your posterior tibial pulse. You may find that the examining practitioner also checks something called capillary return, and this is to assess for any vascular compromise or circulatory problems. And this is normally done just by putting some gentle pressure on your nail bed for about 3 seconds, releasing the pressure and seeing how long it takes for the blood flow to return to your extremities. We will also check the temperature of your foot, and the way that we do this is just by placing a hand on and also doing a visual examination to look for any redness, swelling or heat or anything also like that. And then last of all, we will do the monofilament testing using the Semmes-Weinstein method, and this will be discussed in more detail on the next slide. So as you can see, this is a leaflet describing the Semmes-Weinstein 10 gram monofilament test, as I discussed in the previous slide. Now, when you come for your diabetic foot exam, you'll just know it basically as a pen-like object with a little piece of monofilament on the end that the practice nurse or the doctor or the diabetes specialist nurse, if you're being seen in secondary care, will use to check for sensation. So if we look at the patient information leaflet and we go across from left to right, the left-hand column talks about risk classification and any need for referral or follow-up, and that is just an indicator to us as healthcare professionals as what we would class as red flags and when to refer on to podiatry or a diabetic foot multidisciplinary team or into secondary care. It also talks about the importance of patient education and reiterates, which is what I've just said, which is using proper footwear, not going barefoot, inspecting your foot daily, and then also look between the toes and on the sole of your foot, and remember to report promptly any foot lesions, discoloration or any swelling that you might be concerned about. The centre portion of the patient information leaflet actually goes through the procedure that we do use when we do this test in primary or secondary care. So as you'd probably be aware, if you've had one of these done before, it's looking at the sensation on the base of your toes and also at various aspects of your feet. Now, before I do this test, I will usually talk the patient through the actual implement, because if you've not seen it before, some people have anxieties that it can come across as the appearance of a needle. So I will just reassure my patient that it isn't a needle, it is basically just a piece of monofilament, very, very similar to catgut. And if you allow me, I'll test it on your arm first just to make sure that you know what you're expecting to feel. And then when the test is performed, as you can see there, we go on various places on the ball of your foot, also underneath your toes, and again this leaflet reiterates the purpose and the importance of feeling for the foot pulses. And then the last section on this information leaflet is basically just a foot examination pocket chart, and it talks about all what to expect when you go in to see your practice nurse or your clinician when you go in for your diabetic foot exam. If you do need to be referred to podiatry, this is just an example of a referral form that may be used, and this is something that I would use within my primary care area to refer to secondary care. It's completed after I've completed the diabetic foot exam in surgery myself, and as you can see, it talks about the laterality of the foot. Is it the right foot, the left foot, or is it a bilateral problem? It asks what sort of problems or symptoms the patient's been having. So is there any intermittent claudication? Intermittent claudication refers to any pain that you may get on walking. It talks to any ischemic foot pain, and again, ischemic foot pain is associated with the pain common to peripheral neuropathy. And then it also talks about any neuropathic symptoms such as the numbness or the loss of sensation or the pins and needles that we were talking about earlier. So it just has a section for us to fill in underneath about the outcome of the monofilament test. It asks if there's any risk factors going on with the patient, any previous foot ulcer history, any foot deformity, any skin changes, have you been a smoker or an ex-smoker, poor eyesight, poor glycemic control, any previous amputations, and Charcot in your left or your right foot. Now, Charcot foot or Charcot arthropathy is another complication of peripheral neuropathy, and if this is developed, it's usually as a result of poor glycemic control and poor management of peripheral neuropathy, and it can actually go on to lead to foot deformity. So it can also say finally at the bottom the risk category of the patient, and as you can see, it talks about an ulcerated foot, high risk, intermediate risk, or low risk. So this would be completed by myself or any other clinician and then sent to podiatry in secondary care. So how do we prevent neuropathy? Well, first of all, by annual screening, or at least annual screening. Then this will not only be an holistic assessment of your overall diabetes management, but particular attention will be paid to your foot and your foot exam. Overall, good diabetic control is absolutely essential, as is the effective management of hypertension and raised cholesterol. And there's a lot of research and clinical studies out there that support even a very, very slight decrease in hypertension can have a beneficial effect on the reduction of peripheral neuropathy. As we discussed earlier, smoking is a predisposing factor for neuropathy, so at each consultation you will be offered smoking cessation advice. If you feel it's appropriate, we can refer you into something called the NHS Quit Squad, or if you feel that you're able to achieve that yourself, we will give you any additional support around that. Alcohol reduction is also something that will be addressed. The weekly recommended alcohol units for both men and women currently stands at 14 units a week. So if you're well within that limit, then you should be absolutely fine and you'll reduce your risk enormously. But if you are drinking in excess of 14 units a week, as discussed earlier, this can have an impact on peripheral neuropathy. And you will also be encouraged to have regular review by chiropody or podiatry. And all these preventative factors have been validated by research by Lim et al. And Wound Source in 2017. It's important to talk about weight management. So out of all the risk factors identified, obesity remains the second most significant metabolic risk factor for diabetic peripheral neuropathy. Effective weight management, referral to a dietitian if appropriate, and diabetes education programs such as Expert Diabetes or Desmond can help control symptoms and reduce disease progression. And again, this was supported by research by Callahan et al. In 2022. I can't that reiterating of the importance of patient education at each contact. And within your surgery or clinical environment, you'll probably find that the practitioners will have diabetes foot education posters up on the wall, or you may indeed be given a diabetes foot prevention leaflet. And this is an example of one on here from Diabetes UK, and it's a really good patient resource. So it talks about the importance of keeping active. It talks about the identification of foot risk status and the action to take, and the level of risk and any corresponding action to that. And it's saying that the annual foot review is available to anybody with diabetes over the age of 12 years. So as I said, this is a really good patient resource to reiterate any advice and education that you may have been given at your consultation. Let's have a think then about the treatment of neuropathy. So first of all, it's important to treat the underlying cause. And if you've got an underlying vitamin D deficiency, this can be corrected by oral medication or vitamin D injections. Lifestyle interventions are of huge importance, so at each face-to-face contact you will be advised always about the importance of diet and exercise and weight management, because we've seen on the previous slide that obesity is the second most important significant intervention for the prevention of diabetic peripheral neuropathy. If you've got associated joint weakness, you may very well be referred on to physiotherapy. If you're a male diabetic patient and you are suffering from erectile dysfunction, this can be treated by sildenafil, or you might know this as Viagra. If this isn't effective for you, there are other alternative therapies that may be available, but these will be discussed between you and your clinician. In terms of pain management, the pain from neuropathic pain can be really uncomfortable. So you might be offered something called gabapentin, you might be offered amitriptyline, you might be offered pregabalin, and all of the three above are particularly good agents for the treatment of neuropathic pain. You may also be prescribed something called duloxetine. Now, people may associate duloxetine with being an antidepressant, and it is used to treat anxiety and depression, but studies have also shown now that it can be of particular benefit in the treatment of peripheral neuropathy. And if you've got some topical discomfort, you may be prescribed something called capsicum cream for topical relief. So let's have a think about the complications of peripheral neuropathy. Hopefully by patient education and a thorough diabetic foot exam at each consultation, these will be prevented. But if your condition isn't managed effectively, you could go on to develop a diabetic foot ulcer. You may also develop gangrene, and surgical debridement or an amputation may be required. Now, this could just be an amputation of a single or multiple digits or whole or part of the foot. If you've got associated cardiac autonomic neuropathy, you may very well end up with cardiac or circulatory problems such as chest pain and arrhythmias, and if that's the case, you may very well be referred to cardiology for management of those symptoms. Any pain is going to affect your mental health, and if you do develop a mental health disorder, this can affect motivation and concordance and ability to want to do anything about self-management of your condition. So if you do develop any kind of mental health disorder, you may find that your clinician will prescribe you either anti-anxiety medications or perhaps an antidepressant. If you've got any other comorbid long-term conditions, you may feel an impact on those because of the potential loss of mobility. And as I mentioned in one of the earlier slides, again, if your peripheral neuropathy isn't managed effectively, you could go on to develop Charcot arthropathy, which again, if left unmanaged and untreated, will lead to deformity of your foot. Now this slide isn't a particularly pleasant slide, but unfortunately it just gives an illustrative example of what can happen if diabetic peripheral neuropathy is left mismanaged. So on the right hand side of the picture, you're looking at what I would probably say a moderate risk in terms of diabetic foot ulcers, and certainly the one on the left, as you can see, unfortunately this poor person has had a couple of digits amputated, they've got extensive tissue damage, and if you look quite closely you can also see some damage down to the bone. So it's really important that this is managed by us in terms of correcting things like your circulating high blood sugars, your high blood pressure, your high cholesterol levels. But in terms of yourself as a patient, it's important that you take on board any advice that you are given about diet and lifestyle modifications, because the last thing we want you to do is end up with a foot like this. Some areas of primary care may actually have within the local area a diabetic foot multidisciplinary team, and this will obviously consist of a podiatrist, a diabetes specialist nurse, a diabetologist, perhaps a dietitian, maybe a physio, and the benefits of referral to this service are outlined below. So it can reduce major lower limb amputation rates in diabetic patients. It will also reduce any emergency admissions due to diabetic problems by 50%. The reduction in the length of a hospital stay due to diabetic foot problems may be facilitated, and this in turn will reduce any burden on the NHS. It's going to improve staff and patient awareness of diabetic foot disease, and most importantly of all, it's going to improve quality of life for you, the patient. And if you look at the little caption on the right hand side, as you can see, happy patients equals successful practice, and that's what we're all aiming for as clinicians. So there might be several take-home messages from this teaching session and presentation today, but for me the number one take-home message is that obesity is the second most significant cause of diabetic neuropathy. Now that's something that you can concentrate on as the patient by addressing diet and lifestyle interventions. And it's important always to reiterate diet and lifestyle interventions at every patient contact, and that's where my role as a practice nurse and any other clinician comes into play when we do your diabetic holistic review. That concludes the presentation and the teaching session. Thank you very much for listening, and I'd be happy to take any questions that you may have. Thank you.